that presents with a history of cardiac catheterization, anticoagulation with heparin, a sudden onset of hypotension, tachycardia, flat neck veins, and back pain. That patient has signs consistent with retroperitoneal hematoma due to the bleeding from the arterial access site. Local vascular complications at the catheter site would be bleeding, hematoma. This hematoma may be localized or with retroperitoneal extension. They may show signs of arterial dissection, acute thrombosis, pseudoaneurysm, or arteriovenous fistula formation. These are the most common complications for cardiac catheterization. Most hemorrhage or hematoma formation occurs within 12 hours of the catheterization. Patients with hematoma present with localized discomfort and or swelling of the soft tissue. If the arterial puncture site is above the inguinal ligament, the hematoma can extend into the retroperitoneal space, even with minimal visible localized hematoma, and presents with sudden hemodynamic instability and ipsilateral flank or back pain. Usually, the diagnosis is confirmed with a non-contrast CT scan of the abdomen and pelvis, or an abdominal ultrasound. To treat such patients, we usually do supportive treatment, and you monitor them in the intensive care unit. You put them on bed rest, and then you give adequate intravenous fluids or blood transfusion depending on their states hemodynamically. When you do surgical repair of the hematoma or the retropharyngeal hemorrhage, it is usually not required. Since local hematoma formation is not uncommon, patients should be advised to avoid strenuous activity or lifting heavy objects for 1 week post-catheterization. Radial artery approach leads to fewer local vascular complications, which has led to an increasing number of cardiac catheterizations being performed via this approach.